Welcome to our video on the medical complications of pregnancy. Let's get started. Here's our overview slide. Let's begin by discussing hyperemesis gravidarum. This is a severe form of morning sickness that can be seen in some pregnancies. Unlike typical morning sickness, hyperemesis gravidarum is associated with weight loss and ketosis. For most patients, morning sickness and hyperemesis gravidarum improve after the first trimester of pregnancy. However, for some patients with a severe case, vomiting can last all the way until term. There is no clear etiology for this condition. However, there is some thought that it may be related to elevated levels of beta-hCG in pregnancy or changes in thyroid hormones. There also seems to be an increased risk of hyperemesis during molar pregnancies. In molar pregnancies, the hyperemesis is thought to be related to the extremely high levels of beta-hCG present. Hyperemesis gravidarum is diagnosed when a patient experiences persistent and severe vomiting during pregnancy. In order to be diagnosed with this, the patient needs to have experienced a weight loss that is greater than 5% of their pre-pregnancy weight. In addition, they also need to have ketones on their urinalysis. The most crucial part in the management of hyperemesis gravidarum is ensuring that the pregnant mother maintains adequate nutrition. This can be encouraged by eating frequent and small meals throughout the day in order to decrease periods of hypoglycemia, which are thought to contribute to nausea. If the patient is unable to consume any food, they may require a feeding tube or parenteral nutrition until the vomiting improves. If the patient is dehydrated, they may require rehydration with IV fluids and repletion of any electrolytes that are abnormal. Additionally, if the patient's vomiting has been severe and they have been unable to consume any nutrition, they may require thiamine supplementation in order to prevent Wernicke's encephalopathy. The first-line antiemetic for the treatment of this condition is promethazine. In addition, patients can also take vitamin B6 and doxylamine to decrease nausea. All right, let's try a question. A 27-year-old G1P0 woman at 15 weeks of gestation is brought to the physician by her husband due to recent onset of confusion. She has commonly been forgetting her husband's name for the last 3 weeks. She reports severe nausea and vomiting in her first pregnancy. Her pre-pregnancy weight was 70 kilograms, while her current weight is 65 kilograms. The physical exam reveals an irregular ataxic gait, slow extraocular movements, and horizontal nystagmus. Supplementation with what substance could have prevented this patient's current neurological findings? All right, this patient presents with confusion, ataxia, and ophthalmoplegia manifested as slow extraocular movements and nystagmus. Additionally, she reports severe nausea and vomiting in her first pregnancy, and in the current pregnancy, she has lost more than 5% of her pre-pregnancy weight. This presentation is most consistent with Wernicke encephalopathy caused by hyperemesis gravidarum. Thiamine supplementation should be initiated in the pregnant woman with hyperemesis gravidarum to prevent the development of Wernicke encephalopathy. Okay, now let's move on to discuss thyroid disease in pregnancy. During pregnancy, there are several physiologic changes that affect levels of thyroid hormone. First, there are increased levels of thyroxine-binding globulin and sex hormone-binding globulin. The increase in these binding hormones leads to a decreased amount of free active hormones circulating throughout the body. Additionally, pregnancy itself is an increased metabolic state, which will affect the metabolic demands of the body. We'll first discuss hypothyroidism associated with pregnancy, since pregnancy itself can contribute to a hypothyroid state. Hypothyroidism during pregnancy is most commonly due to Hashimoto's disease or previous ablation. When a patient learns that she is pregnant, her levothyroxine dose should be increased by 25 to 30%. This dose should be adjusted every 4 weeks until her TSH remains stable. After a period of stability has been achieved, her TSH can then be monitored just once per trimester. It's important to properly treat hypothyroidism during pregnancy because low levels of thyroid hormone can have detrimental effects on the fetus. These complications include intrauterine growth restriction, congenital thyroid deficiency, and stillbirth. Okay, now let's discuss hyperthyroidism during pregnancy. Hyperthyroidism during pregnancy is most commonly secondary to Graves' disease. In a patient with Graves' disease, the TSH receptor stimulating antibody levels should be checked at the first prenatal visit. These stimulating immunoglobulins can lead to a fetal goiter if they're elevated. Therefore, the thyroid should be monitored closely on ultrasound in these pregnancies. If patients have hyperthyroidism during the first trimester, they should take propylthiouracil. Then during the second and third trimester, they can switch to methimazole. This regimen is due to the fact that methimazole has been associated with teratogenic effects during the first trimester, such as aplasia cutis, omphalocele, tracheoesophageal fistulas, and choanal atresia. While propylthiouracil is also associated with congenital malformations, they tend to be less severe. This explains why the mother should take propylthiouracil for the first trimester and can then switch to methimazole during the second and third trimesters when the risk for teratogenic effects due to methimazole is decreased. Throughout the pregnancy, the mother should be monitored for symptoms of hyperthyroidism and have her TSH regularly checked. Serial non-stress tests can also be performed closer to delivery to evaluate for fetal tachycardia, which may be a sign of hyperthyroidism in the fetus. This is an image of aplasia cutis, which is a potential teratogenic effect of methimazole. This is characterized by a congenital absence of skin. It usually appears as a well-demarcated lesion, like in this image. While this image shows an area that is healed over with scarring, other cases of aplasia cutis can appear as more ulcerated lesions that involve deeper layers of the skin. Any patient experiencing symptoms of hyperthyroidism during pregnancy can be treated with beta blockers to alleviate the symptoms. A more severe complication of hyperthyroidism during pregnancy is thyroid storm. A thyroid storm can be precipitated by infection, surgeries, or the stress of labor and delivery. The signs of a thyroid storm include a fever greater than 103 degrees Fahrenheit, severe tachycardia, and changes in mental status. Thyroid storms during pregnancy are associated with a high risk for maternal heart failure. Another thyroid disease that can affect pregnant mothers is postpartum thyroiditis. This is due to subacute autoimmune inflammation of the thyroid that leads to inflammation and lymphocytic infiltration. This inflammation and infiltration leads to the destruction of follicular cells. The destruction of these cells then leads to the release of preformed thyroid hormone. This condition can present in a variety of ways. It may present as hypothyroidism due to a lack of thyroid hormone after destruction of the cells. It can also present as hyperthyroidism due to the sudden release of large amounts of preformed thyroid hormone as the cells are destroyed. Patients may also present initially with symptoms of hyperthyroidism and then progress to hypothyroidism. Postpartum thyroiditis has a good prognosis, with most women returning to a euthyroid state by 1 year postpartum. All right, let's try another question. A 23-year-old woman presents at a preconception visit. She's planning to get pregnant the next month. She has no specific complaints. Her past medical history is significant for Hashimoto thyroiditis, treated with levothyroxine. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 125 over 80 millimeters of mercury, a heart rate of 82 beats per minute, and a respiratory rate of 16 breaths per minute. What kind of modification should be made to this patient's medication regimen after she gets pregnant? All right, this patient presents at a preconception visit. She has a past medical history of Hashimoto thyroiditis treated with levothyroxine. Since pregnancy-induced high estrogen levels stimulate hepatic synthesis of thyroxine-binding globulin, the free thyroxine levels will likely decrease during pregnancy. Therefore, the levothyroxine dose should be increased by 25 to 30% after the woman with hypothyroidism gets pregnant. Okay, now let's move on to discuss neonatal lupus. Systemic lupus erythematosus affects many organ systems throughout the body. These complications from lupus, such as hypertension and renal disease, can affect pregnancy. Women with lupus have an increased risk of developing preeclampsia and intrauterine growth restriction. They also have an increased risk of miscarriages in the first and second trimesters and preterm delivery. When a patient with lupus becomes pregnant, some of their medications may need to be changed. However, the patient should be instructed to continue their aspirin and corticosteroids. However, they should discontinue their cyclophosphamide and methotrexate due to the teratogenic effects of these medications. Cyclophosphamide can lead to growth restriction and hypoplastic limbs, and methotrexate is a folate antagonist that can lead to spontaneous abortion. Lupus can also have an impact on the fetus. This is because the maternal antigen-antibody complexes found in a patient with lupus can cross the placenta, causing symptoms of lupus in the neonate. The major manifestations of neonatal lupus are cutaneous and cardiac complications. The rash of neonatal lupus typically consists of erythematous annular lesions. These lesions are most commonly present on the scalp and around the periorbital regions of a neonate. Occasionally, this rash can present even after the maternal levels of antibodies have fallen. The most concerning complication of neonatal lupus is the potential for congenital heart block. Some patients with lupus will have anti-Rho and anti-LAW antibodies, which can cross the placenta. These antibodies are tissue-specific to the cardiac conduction system and can lead to destruction of the atrioventricular node. Destruction of the AV node will then lead to varying degrees of congenital heart block. If a patient has anti-Rho or anti-Law antibodies present on labs at their first visit, they should be closely monitored throughout pregnancy with fetal echocardiography. The fetus is most likely to develop heart block during the second trimester of pregnancy. If severe, the congenital heart block can be irreversible. In these cases, the infant may require insertion of a pacemaker. Okay, let's move on to our last topic, which is peripartum cardiomyopathy. This is a type of heart failure associated with pregnancy. It's typically due to a dilated cardiomyopathy. Peripartum cardiomyopathy occurs towards the end of pregnancy. It can develop immediately before or during birth and up to 5 months after birth. There is no clear etiology, but it may be associated with some degree of baseline cardiomyopathy or post-infectious cardiomyopathy. The diagnosis is with echocardiography. Echocardiography in a patient with peripartum cardiomyopathy will show a dilated heart with an ejection fraction that is between 20 to 40%. If a patient develops peripartum cardiomyopathy after 34 weeks of pregnancy, then the baby should be delivered. However, if it's earlier than 34 weeks, betamethasone should be administered to promote fetal lung maturity. The management of symptoms secondary to heart failure will be similar to that of any patient with heart failure with reduced ejection fraction. This includes diuretics, inotropes such as digoxin, vasodilators, and supplemental oxygen as needed. However, it's important to remember that ACE inhibitors, angiotensin receptor blockers, and mineralocorticoid receptor antagonists are contraindicated during pregnancy and should not be used. After delivery, most patients will experience improvement of their cardiac function, with many returning to their baseline. Okay, let's wrap up with a final question. A 24-year-old G1P0 woman is admitted to the labor and delivery suite at 39 weeks of gestation after spontaneous rupture of membranes. Her pregnancy has been uncomplicated. She has a past medical history of systemic lupus erythematosus treated with hydroxychloroquine. Her cervix is dilated to 4 centimeters and effaced by 60%. Several hours after admission, she delivers a baby boy. The physical exam of the newborn reveals a diffuse rash, most prominent in the periorbital regions. His AST is 1000 and his ALT is 1500. Electrocardiography shows severe bradycardia with complete atrioventricular dissociation. What is the most likely pathophysiology of this newborn's presentation? Alright, this patient has a past medical history of systemic lupus erythematosus. She delivers a baby boy with a diffuse rash, severe transaminitis marked by increased levels of AST and ALT, and an electrocardiographic finding consistent with third-degree AV block. All of these clues point to the diagnosis of neonatal lupus. And recall that this is caused by transplacental passage of maternal anti-Rho antibodies that damage multiple fetal tissues, including the cardiac conduction system. So, in answer to the question, the pathophysiology of this newborn's presentation is related to transplacental passage of maternal anti-Rho antibodies resulting in neonatal lupus. And that concludes this section.